right, so we're going to talk about the approach to the patient with coma and altered mental status. So this was my dog Casper. One day, this is a true story. I would never BS you. But one day I came home and he was somewhat unresponsive. I thought maybe he was hitting the alcohol over there. It turned out he actually was in DKA. So I got very interested in this subject because I love that dog. So I'm going to start with a case, and this is one of my first cases from UHB. All right, so 72-year-old patient with a history of diabetes, hypertension, CHF, coronary artery disease, UTIs. Sounds familiar? See like 5 of these patients every shift at UHD. Presents with a 3-day history of anorexia, coughing, shortness of breath, and increasing confusion for 3 days. Her medications are glyburide, aspirin, Cipro, metformin, Lasix, digoxin, and Lopressor. Almost as many medicines as I take every day. Her blood pressure, a little soft, 100/70. Heart rate is 68, but it's irregular. Respirations are somewhat increased at 24. And just a low-grade fever, maybe, 99.8, but she keeps spitting out the thermometer. So I don't know how much I trust that, right? She's confused and disoriented, but she moves all her extremities, and there's no evidence of focal neurological findings, right? So I want you to think about what further evaluation you're going to do for this case, what are the most likely diagnoses, and how are you going to manage this case? And we'll get back to her later after my lecture. Okay, so what are our goals and objectives? Learn how to evaluate patients with altered mental status and how to manage patients with altered mental status. Right? So we're going to talk about some important clinical considerations when you have a patient with altered mental status, how to approach and evaluate them, the differential diagnosis, and the management. And especially, I'm going to emphasize a little bit about delirium in older patients. So coma and altered mental status are very common. These patients can very rapidly deteriorate. And the etiologies, the underlying things, which is the main way you're going to treat these patients or treat the underlying cause that's causing these things, they can be very dangerous. So an important clinical consideration, the ABCs always take precedence, especially with decreased mental status. Another important consideration is altered mental status often is the first sign of severe underlying process, and it's a common presentation of many diseases, especially in older patients. So one other important clinical consideration you always want to ask yourself is this caused by something toxic metabolic, or is this due to structural disease? And why is that important? Because the management of toxic metabolic etiologies, which are going to be most of them, especially in older patients, is primary medical, right? Antibiotics, fluids. The management of focal neuro disease may be neurosurgical, right? Treating a subdural, treating an epidural. So the determination of a surgically correctable structural lesion is based on focal findings. That makes you suspicious. Oh, they're not moving that side well. Oh, they were complaining of numbness on one side, right? So focal findings on your neuro exam, and you prove that with a CAT scan. So what do you see here? What is this? A big epidural, right? All the medicines in the world are not going to cure this. You got to get a neurosurgeon for this, right? Okay. So what is the definition of consciousness and sleep and lethargy and stupor and coma? So consciousness is the power to be aware and to choose and to respond appropriately to appropriate stimuli. So when I was practicing this lecture, when I first started it many years ago, I actually put my family into coma. Bad joke. Okay. All right. So coma is a state of unresponsiveness from which the patient cannot be aroused. Right? So when we look at altered mental status, there's two things you want to look at. Level of consciousness, right? And the content of their consciousness. Are they making sense? Even if they seem to be awake, are they making sense? By the way, great movie if you've never seen it. Wonderful movie. You have some free time after you graduate. Watch it. Okay. So altered mental status, one thing you always want to ask yourself, is this an organic problem? Is this really medical? We're at our best. Or is this a functional psychosis? Is this schizophrenia? Right? Do I need a wonderful clinician like Dr. Buckridge, or do I need Sigmund Freud? Right? So what can help you with that? Studies have shown that a first time something that looks like psychosis over the age of 50, more likely to be organic. Right? Very unusual for schizophrenia to start past the age of 50. So that should make you suspicious. The inability to pay attention, right? Because they're so sick, they can't pay attention. That points you more to organic. Hallucinations can point you more to organic, right? With organic things, visual and tactile hallucinations are much more common than auditory, right? Especially different than organized auditory, different than the guy who's grasping in DTs at an invisible string versus the guy who says, oh, Gernsheimer is here to save me and bring me to heaven. You're not going to hear that in delirium, right? That's more psychosis. So what about dementia versus delirium? So dementia is really acute, right? Matter of usually days, even hours sometimes, right? Dementia is more chronic. And also dementia, the level of consciousness usually is decent until near the very end. Now, one thing to remember is patients who have dementia are much more likely to suddenly become delirious. Why? A lot of them are frail and they get infected easily and get dehydrated easily. A lot of them are on many medications that can cause delirium. Okay, so I gotta tell this. Can I tell the story of my Aunt Rosie again? You remember that story? Some of you would. But we're living in Brownsville, and my mother was taking care of my great Aunt Rosie. And Aunt Rosie had dementia. She forgot how to speak English. She would only speak Yiddish. She wouldn't even remember me, but always remembered my mother, who she had brought over here, helped bring over here as an orphan. So one day, my Aunt Rosie started to act differently. She wouldn't eat. She didn't recognize my mother, which was very unusual. And then she started to try to run down in the street to go back home to a little shtetl, a little village in Russia, right? So my mom took her to Kings County, and they admitted her. They admitted her to the psych ward. She died 3 or 4 days later. Knowing what I know now, she probably had delirium on top of her dementia. It was the summer. She probably was dehydrated. Maybe she had an infection. Okay, so you don't want to miss that, right? You have someone with dementia, never say, oh, it's just dementia. The family is trying to dump this patient, right? Always do a good evaluation. If you hear this is a change, you have to start worrying that this could be delirium. So what is delirium? An acute confusional state characterized by an alteration of consciousness with reduced ability to focus attention. right? All those are keys when you're evaluating someone for delirium, particularly older people. So why is delirium important in elderly? So there are some studies, including by ASAP, that shows it's common and increasing. It's associated with increased morbidity and mortality. It's often missed in the ED, and it increases the cost and resource use. So why is it often missed in the ED, right? So Dr. Buckridge always likes to say, the eye doesn't see what the mind doesn't know. If you don't think about it, you're not going to see it, particularly in the elderly. So we always think of, the guy on angel dust, he's going nuts. He's, taking a swing at Gernsheimer, throwing a defibrillator at somebody else like Dr. Willis or Dr. Hassel, right? But delirium really, you got to look at for certain things. One is a fluctuating level of consciousness, particularly in the elderly. At one moment, they may be quiet. The next moment, you go to draw blood on them, and they're screaming, they're yelling, they're trying to scratch you, right? It's caused by an underlying acute medical condition. These patients are ill. They will die if you miss something like sepsis in them. And there are a couple of good screening things you can do in the elderly. One is called the RAS, and the other is called BCAM, which we'll look at. So why is it missed, delirium in the elderly often? Well, we always, again, think about delirium as this wild guy on cocaine or angel dust who is taking a swing at Gernsheimer. But in the elderly, the more common type of delirium is a hypoactive delirium. They're quieter, they're in their own little world, they may be fidgeting, talking to themselves, right? But no bothering anybody until they have a cardiac arrest, right? The other type of delirium is hyperactive, where patients are really wild. And then it can be mixed. And that often you see in the elderly, although most common is hypoactive. When you bother them, they become hyperactive, right? Starting to stick that IV in them or send them to CAT scan, right? So this is the Richmond Agitation Scale. And this is a good way to start screening. The nurses can do this to look at their level of consciousness. And it can go anywhere from coma up into wild swinging Gernsheimer land, right? So they can be screened by the nurses for their level of consciousness. And they can also be screened for the inattention, very characteristic of delirium, right? If they don't have either of these two things, they have no delirium. But if it's positive, then you could do something called BCAM. And what is that? That's the brief confusion assessment method, which, and we're not going to spend a lot of time on this, but it gives you an idea, is there delirium or not, by asking some simple questions as you examine the patient or thinking about some simple things. So we always talk about the ABCs, but once you've made sure the ABCs have been taken care of, you want to look at the disability, right? The D. So that's a quick neuro exam. And you want to look at the level of consciousness, their pupils, make sure they're equal and reactive, and their motor, make sure they're moving all four extremities, right? If they're not, then obviously you're worried, you got to get the neurologist who's going to ask you to do a urine analysis first, right? But you want to look at those. So the level of consciousness, a quick one is ABPU. Are they alert? No. I'm worried now. Do they respond to verbal stimuli? No. Do they respond to painful stimuli? No. Well, then they're unconscious and they're in coma. You better take care of their ABCs, right? A little more complicated, the Glasgow Coma Scale. They love to put this on the written board, right, Dr. Hassel? Every year, at least one or two questions on calculating the Glasgow Coma Scale. It looks at the best motor, the best verbal, and the best eye opening. with 6, 5, and 4. Maximum is 15, minimum is 3. And coma is 8. Anything 8 or below, you better take care of those ABCs, right? And even a drop, you might start off with someone who's around a 14 or 15, and suddenly they become 2 or 3 lower. That's something that should alert you that there's something acute going on. Now, some pathophys, to have decreased level of consciousness, you either have to have bilateral cortical disease, diffuse diseases, or you have to have a lesion in your reticular activating system, right? So cortical disease requires really diffuse kind of disease, bilateral disease. And one study in elderly, the 4 most common general categories that caused delirium were toxins, including adverse drug reactions in there, hypoxia, including shock and not delivering oxygen to that brain, hypoglycemia, and sepsis. Right? RAS lesions, they can either be caused by supratentorial or infratentorial pressure, someone's herniating, or an intrinsic brainstem lesion. And you're almost always going to find focality there. You're going to have a weakness or a cranial nerve problem or something like that. Okay, so what is our general approach to a patient with altered mental status? So always again, and I sound like a broken record as my wife says I am, but stabilize the ABCs and then evaluate, right? Don't let them die on you. Stick an IV in them, draw their blood, and then don't forget to think about important therapy. What do I mean by don't? One is dextrose. Get a finger stick, right? They used to call syphilis the great imitator. For me, when it comes to altered mental status, the great imitator is hypoglycemia. I have seen it do so many things. Anything from just being nervous to being stuporous or lethargic, to having seizures, to having a hypoglycemic hemiplegic syndrome. In fact, the only thing the Annals of Emergency Medicine ever published with Gernsheimer's name on it was a case of hypoglycemic hemiplegia of a poor woman who came to clinic at Lincoln, and they told her not to eat, but didn't tell her in Spanish not to take her insulin. And while she was waiting hours for her appointment, it suddenly looked like she had a big stroke. And it turned out to be she was hypoglycemic with a sugar of less than 30, right? So always check that finger stick. Always oxygen. Make sure they're not hypoxic. Make sure they're not having a rising PCO2, right? N is naloxone. Think about, especially in young people, maybe an opiate overdose, and consider giving a dose of naloxone. And T is thiamine. For very malnourished or alcoholic patients. To be very honest, the old teaching they may have taught you in medical school that you should always give thiamine before glucose if they're hypoglycemic, that's baloney. If they're hypoglycemic, you give them sugar. You don't need, you can give the thiamine later. You give them sugar, right? The brain needs sugar and oxygen. Can wait for the thiamine. And then always monitor them closely because they suddenly may crash on you. So what about the history, right? It always starts with the history. So get it when you can because you can't rely on the patient's history. And this is when you want to get EMS, get the history from them, what they saw in the house, what the family may have told them. Call the family, call friends, right? This is important in this kind of situation. And you want to get an ample history, right? Allergies, what medications they're on, their past medical history, their last meal, their last period, and then a good HPI, a good history of the event. That'll give you the clue of what may be going on here. Right, and then you're going to do a good physical exam, right? And you always start with vital signs because vital signs are vital. Right? Why is this patient tachycardic? Why does this patient have a low O2 sat? Right? And always with that fifth vital sign. Okay. You want to look for signs of trauma, right? You don't want to miss the stab wound in the back or the gunshot wound in the back. And I've seen them both missed, right? And do a good neuro exam, looking for focality. One side different than another, one cranial nerve different than another, right? Complete neuro exam would involve all these things: the mental status, the cranial nerves, motor and reflexes, sensory and cerebella, and brainstem testing. So what about herniation? If you did have a bleed, which you don't, where then you're going to really need a neurosurgeon, right? So often the earliest sign is decreased mental status, right? And then you want to check those vital signs. Suddenly the pressure goes up and the heart rate goes down. What's that called? Cushing sign, right? A sign of impending herniation. You want to look at the pupils, make sure they're equal and reactive, right? Look at the motor, make sure they're equal on both sides. And then you can check for ocular vestibular reflexes in patients you think may be dead who are not, right? And always remember GLG. So what does GLG stand for? God loves Gernsheimer. He made things symmetrical, so it would be easier for me, right? So if things are not symmetrical, they should worry you. They may be nothing, but they may be something big, right? Okay, and then labs. You're going to get your usual labs, but then you're always thinking maybe you need some special blood tests, right? You think it's an overdose, always get a Tylenol and an aspirin level, right? You're going to get your VBGs and maybe ABGs. You're always going to have them on that fifth vital sign, that pulse ox. You're going to get an EKG to make sure they didn't have an arrhythmia that threw an embolus to their head. And you're going to keep monitoring their vital signs and keep monitoring their O2 sat. If they're in coma, you're going to maybe have to place a Foley and get a urine analysis, and it may be a UTOX, although UTOXs often won't help you acutely. What you should do is follow your toxidrome. You say, hey, this looks like an opiate overdose. Try your naloxone, right? Don't wait for that UTOX to come back before you give them naloxone. They may stop breathing on you. And if I had time, I would tell you a story how one of my grads got into trouble that way. But we'll skip it. You're worried about pneumonia? Most common infection in older people is pneumonia, serious infection. Then get an x-ray. You're worried about head trauma, any trauma above the clavicle. Then I'd get a CT scan, and I would get the CT scan of the spine. We don't really use the x-ray that much anymore, right? Not as accurate as a CT scan. What about the CT scan? So if you find any focality, I would definitely get a CT scan early. If you don't find any evidence of something going on neuro from the history, there's no terrible headache, there's no sudden weakness or anything else, I would look for more metabolic causes. And if I don't find that, then maybe I would do the CT. But if you find something focal, yes, then you should push to the CAT scan, but send the patient there in a safe way. Right? Lumbar puncture, have to be careful with it. So there's a nice study out of Cook County many years ago that said, when can you do a lumbar puncture without a CT scan? And when should you probably get the CT scan first? So if the patient has head trauma, get the CT scan first. If the patient is elderly, probably better off with the CT scan first. Right? If the patient has HIV, probably better off with the CT scan first, right? So you don't miss that big toxo lesion or that big lymphoma in their brain. But if you're worried about meningitis and you can't get a CT scan, then start them on antibiotics. And then you can do your lumbar puncture. You're not going to ruin your CSF, especially nowadays when we can test so much in the CSF. So if you think at all someone has meningitis and you want to get that CT scan, Start them on the antibiotics early. Draw your blood cultures. When I was the director of the ED at Lincoln, and I would have to go and defend the department in court, no one ever said to me, you know, your guys screwed up because they gave antibiotics before they cultured the CSF, right? Luckily, we didn't have any ID experts in the jury box. But what we would get in trouble with if people suspected meningitis and hesitated to give the antibiotics, right? That's when we lost those cases, right? And then what about EEG? Well, if you think someone is in status epilepticus and they may not be jerking anymore, but they're not waking up, then you can ask Dr. Zia, can he get you an EEG? To be very honest, I've had a lot of trouble at UHD getting EEGs, so good luck with that. So what is this? This person did have the complaining of a headache and then altered mental status. This is a case from UHD, or a very similar case, an older man who turned out had fallen about a week before. What is this? Big subdural, look at that shift, right? GLG is not symmetrical, right? Look at all this stuff and all that shifting over, right? And this patient actually got neurosurgery and did well. Okay, so what the mnemonic I like for my differential diagnosis here? Okay, well, I like the one that I plagiarized from Tintinelli. It's the vowels plus tips, right? So A, alcohol, Dr. Hassel. Just saying. Okay. A, adverse drug reaction. Very common in the elderly. Very common, right? E, electrolytes. Sodium and calcium are the big ones, and dehydration. Those are big in older people with delirium. You don't want to miss those, right? E, encephalopathy, which can be hypertensive or hepatic or uremic. Endocrine, hypo and hyperthyroidism. And we talked about dementia, right? And it being more chronic. One thing I just want to say is, even with dementia that's chronic, there are 3 diagnoses you don't want to miss with that, right? And those are hypothyroidism, pernicious anemia, right? And normal pressure hydrocephalus. Those are 3 that can cause dementia that if you catch them, you can at least stop them from progressing. And there's one more that you don't want to miss. Syphilis, right? Tertiary syphilis. That's my big 4. Insulin, too much and they're hypoglycemic, too little and they may come in with HNK, right? And I remember just a couple weeks ago, a great speaker gave a talk on endocrine emergencies in the elderly. You remember who that was? If you don't say it, no candy for you. All right. O, opiates, overdoses, and hypoxia, right? Oxygen. U, uremia, and I've seen uremia do some weird things with mental status. T is temperature, hypo and hypothermia, and toxins like carbon monoxide. T is trauma. T are tumors. T is thiamine and other vitamin deficiencies. And I is a big one in elderly. Infections, brain, but especially systemic. UTIs and pneumonias, right? 4 big infections in the elderly you never want to miss are pneumonia, UTI, abdominal, and skin. Those are the 4 places you should always look for possible infections in the elderly, right? P is psychiatric, and that's a rule-out diagnosis, especially in the elderly. S is space-occupying lesions and strokes, shock, seizures, and syncope, right? So Benjamin Franklin said, an ounce of prevention is worth a pound of cure. So who's at risk for delirium? That patients with decreased vision or hearing, decreased cognitive ability. So patients who have dementia at a greater risk of suddenly deteriorating and getting delirium on top of it, like my Aunt Rosie. Patients with severe illness, patients who are dehydrated, and patients in pain. So how are we going to manage these patients, right? So you're going to always start again with the ABCs and think about the don't therapy and treat it if you find anything that needs it from that. Always treat specific causes. Look for and treat specific causes. Support, hydration, nutrition, analgesia if they're having pain, and always TLC. Always tender, loving care, right? And restraint and sedation as needed. Not quite like this, though. Right? So, what about treatment of agitated elderly patients in the ED? Right? So, again, I like to use the mnemonic TADA. So, number one, T is treat the underlying cause, right? And initially try some non-pharmacological means. Again, T, tender loving care. Let a relative stay with them, right? Let someone talk them down if they can, right? Tolerate. Don't, get upset with them because they're not cooperating and trying to pull out their IV and stuff. Anticipate that they may get worse and try not to agitate them. So ta-da. Right? So this is a nice little slide about what you can use to treat elderly patients who are delirious and who can't cooperate with you, right? And you want to treat both their pain and you may have to treat their agitation. You want to use pharmacological ahead of using brute force like the orthopedics use, right? We're more into TLC than the orthopedics. No offense to them. Okay, so what are some rules we can follow, right? So always start low and go slow. Don't hit them with 5 and 2, right? Yeah, you can hit Dr. Gernsheimer when he has one of his fits in the ED with 5 and 2. But don't do that to most elderly patients, right? You start lower dose, you go slow, you add to it as you need it. Antipsychotics are usually preferred, and to avoid benzos and anticholinergic meds, except for alcohol and benzo withdrawal and some adverse drug reactions, particularly AMS, neuroleptic malignant syndrome, and serotonin syndrome. They're much safer to use a benzo. The other thing I found that very useful, I need the CAT scan an elderly patient who's agitated, right? And I just want to knock them out a little bit. I like Versed. And you start low. Don't give them that 5 to 10 crap. Start with 2. You can always add. It's hard to take things back if they stop breathing on you, but you can always give a little extra as long as you're tolerant, right? Okay. So what antipsychotics are there that you can use? Olanzapine is a good one. Haldol, it's okay as well. Risperidone. And if they have Parkinsonism, they're safer with something like quetiapine. I can't even pronounce it with my dyslexia. Now, if you're going to use Haldol, start low again. Don't give again the 5 and the 2. Start them, 1 or 2, 1 milligram. You can always give more. And you can give it PO, IM, or IV. If you're going to give it IV, which is not approved, check at least an EKG. Make sure they don't have a prolonged QTC, because then that may lead to a torsades, right? And again, quetiapine for Parkinsonism and LB dementia, Lewy body dementia. Right, so what about the disposition, right? You want to get appropriate consultations. When you have a very sick elderly patient, load the boat. Don't be afraid to ask for help, right? Whether it's neurosurgery, poison control, Most are going to be admitted, except for mild intoxication and mild hypoglycemia, although very careful with elderly patients who have hypoglycemia, right? Because they may keep getting hypoglycemic again and again. It's probably safer to at least put them on OBS. Right? So let's get back to our case. So I got my expert, and we're going to revisit our case, the evaluation, the diagnosis, and management. So, of course, she felt hot to me. I promised my firstborn, and I got them to do a rectal temp for me, and it was 102. Finger stick was 30. EKG showed many VPCs. Glucose came back later as 32, but by then she'd gotten 2 amps of D50. White count was 13,000 with 90% polys. Her urine was greater than 100 WBCs when we put in the Foley. Again, I had to promise them my dog if they put in a Foley. Sodium 124, potassium 2.8, B1 was 50, and creatinine was 1.8. Rich, with all your training in nephrology, what does that tell you? What kind of renal failure is that? Pre-renal. Right, that's pre-renal with that BUN to creatinine ratio of 20 or more, though you don't always have it, but that's very suggestive this is pre-renal. And the DIG level is 5.5, right? That's high. More than 2 is high. So what did I do? Right, I was trying to impress everybody. I had just come from Lincoln to UHD and wanted to show them how brilliant I was. So my diagnoses were urosepsis, adverse drug reaction, hypoglycemia, dehydration with a dysrhythmia, and hyponatremia and hypokalemia. So I gave IV D50, 2 amps. I gave a bunch of IV fluid, right, normal saline with appropriate electrolytes. I started on antibiotics. Right, I gave a shot of Zosyn. I got Digibine and gave Digibine for the digitalis toxicity. I stopped all the meds. I monitored and admitted her to the ICU, and she did very well. Any questions? No? Okay. So in summary, ABCs and don't therapy. Don't forget to think about it, especially that finger stick. Get an ample history, do a good physical, do a good neuro exam, treat the underlying specific causes of delirium. When you need to, load the boat, especially if you need a neurosurgeon, get them early, monitor them closely. Here are my references, especially the first one, right? And here are some more references. And that's it.